Look, I sort of stumbled onto this condition in the late 90s when I was still living in Perth. I was actually seen by a patient who was an Australian, a national cycling champion, and she had developed a lot of pain in her leg while she was cycling, and had seen another vascular surgeon who had put a stent in her iliac artery in order to help her. Instead of helping her, the stent had made her symptoms a lot worse. And therefore I undertook an operation whereby I removed the stent and I repaired the artery with what's called a patch. When you put a patch on the artery, what it does is it bolsters the artery and it increases the circumference of the artery by the width of the patch. And in so doing this procedure, her symptoms were alleviated, and in fact by chance I had stumbled on a condition I'd never previously come across called endofibrosis of the external iliac artery, which causes claudication in elite athletes. Now it's an interesting condition because these elite athletes develop essentially vascular symptoms in their legs. They develop pain while they're cycling, and being an athlete, the last thing you would consider is a vascular problem. So I had basically stumbled upon this condition by treating this patient in Perth. And not long after that, an elite triathlete presented to me with this condition of endofibrosis. Now, endofibrosis is where you get a build-up of some thickening in the wall of the artery. And what happens is the artery tends to kink while the athlete is exercising at their maximal capacity. And the kinking of the artery reduces the flow into the leg, causing pain or discomfort while they're exercising. Clearly, if this is happening to an elite athlete, the onset of pain will prevent them from performing at their maximal capacity, and therefore they'll no longer be able to compete on an international scene. So when this occurs in elite athletes, it does require specialist treatment. Now, one of the difficulties is trying to make the diagnosis. Because unless you've come across patients with this condition before, the last thing you'll consider in an elite athlete is a vascular problem. And often on examination, it is difficult to find anything abnormal because the peripheral pulses are all present at rest. And as we associate vascular conditions with elderly, the last thing you would think of is a vascular problem in an elite athlete. However, if you have an index of suspicion, and you can tell from the history that the pain that the patient is describing is in keeping with what we call claudication, or intense pain in the muscles which occurs with exercise and is relieved with rest, then you can make the correct call and arrange the correct test. And the diagnostic test which clinches the diagnosis is what we call a post-exercise duplex scan of the iliac artery. And what we're looking for there is an area of exceedingly high velocity which shows where the kink or the narrowing is occurring. It's important that the scan be performed immediately following the onset of pain, because if you wait 5 or 10 minutes, then the artery will settle down and you'll miss the diagnosis. So what we do in my rooms here, if we see a patient who potentially has this syndrome of claudication in elite athletes due to endofibrosis, is that we put them on a wind trainer. We get them to exercise until the pain comes on. We then immediately do an ultrasound scan on the iliac artery. And if we see an area of high velocity, and what I mean by that, velocity is greater than 500 centimeters per second, then that basically clinches the diagnosis. In addition, you can do what's called an ankle brachial index, and you can compare the one leg with the other. And if the ankle brachial index falls significantly on the affected side, then that too sort of adds more weight to your diagnosis. Now, it's important to make the correct diagnosis because the treatment involves significant vascular surgery. It involves putting a patch on the external iliac artery, which is not a small operation. It's an operation which involves a full general anaesthetic. We need to make an incision in the lower part of the abdomen. What I do is I approach the external iliac artery in what's called the extraperitoneal space, and then I sew a patch, preferably, or almost invariably, I use vein, which is taken from the same affected leg. I use a patch of saphenous vein and I attach that to the artery, thereby bolstering the artery, increasing the diameter of the artery, and more importantly, preventing that artery from kinking again. and that is successful in alleviating their symptoms. Now, I've now treated over 50 patients with this problem, and the results are outstanding.